being employed in the diagnosis of perianal fistula. Currently, the most commonly used modalities are endoanal ultrasound and the MRI fistulography. Starting with the endoanal ultrasound, introduction and advantage of the endoanal ultrasound, it allows 360-degree imaging of the anal canal. It means it allows visualization of the whole circumference of the anal canal in the same image plane with no need for changing the direction of the probe. No probe manipulation is needed once the probe is inserted inside the anal canal. We don't need to propagate the probe inside and outside of the patient. It allows reconstruction of the axial images into coronal and sagittal. No need for immediate image processing. We can finish the examination, discharge the patient, and then do reconstruction and figure out the positive finding. Technique involves equipment, patient preparation and position, technique of examination, and the normal anatomy. Starting with the equipment, here is a rapid illustration of the endoanal ultrasound machine. The probe consists of different portions. The black portion at the tip of the probe containing crystal responsible for image acquisition, and it has numbers from 0 to 5, 0 corresponding to the innermost part of the anal canal, and 5 the outermost part of the anal canal towards the perianal skin. There are 2 side buttons on the side of the probe responsible for the manual propagation of the crystal. Another side button on the opposite side of the probe which is concerned with the image freezing. There is a black mark on the side of the probe which guides us during the insertion of the probe. It should be always directed toward the anterior aspect of the patient. Patient preparation and position. All patients are examined in lateral decubitus knee chest position with no need for bowel preparation or anesthesia. The probe, after being covered with condom and adequately lubricated, is inserted inside the anal canal. It should be advanced as far as the U-shaped sling of the puborectalis. Then it will be automatically withdrawn to a superficial perianal plane. It should be positioned so that the anterior aspect of the anal canal, as shown in the image below, is superior on the screen at 12 o'clock position, the left aspect at 3 o'clock, the posterior aspect at 6 o'clock, and the right aspect at 9 o'clock. 3 planes of examination are acquired. The D plane, representing the anal canal upper third, which is marked by the distinctive U-shaped sling of the puborectalis being of mixed echogenicity in yellow arrows. Intermediate plane, which is marked by the iso hyperechoic external anal sphincter in red arrow, inner hypoechoic internal anal sphincter in yellow arrow, and echogenic intersphincteric fat plane in between in green arrow. Superficial plane is the lower extremity of the anal canal, and it's marked by the hyperechoic subcutaneous portion of the external anal sphincter in yellow arrow. Is an example of the post-processing reconstruction of the axial ultrasound images into coronal and sagittal, with the yellow arrows pointing at the hypoechoic internal anal sphincter, the blue arrows pointing at the external anal sphincter, and the green arrow pointing at the puborectalis. Interpretation and analysis and points to be fulfilled by the endoanal. The anatomy of the fistula was identified considering the primary tract and its relation to the sphincter, whether it's intersphincteric, transsphincteric, supra or extrasphincteric. It usually appears as hypoechoic tract or band. The internal opening identified at the site of the interruption of the hypoechoic internal anal sphincter and should be precisely localized according to clock position. Any collection is defined as abnormal widening of the primary or secondary tract or appears as hypoechoic fluid collection with internal echogenic foci corresponding to the gases. MRI fistulography. Regarding the protocol, the most important is to obtain axial and coronal oblique images which are parallel and orthogonal to the anal canal. Imaging are obtained in coronal, axial, sagittal projection using T1, T2, and stir sequence parameters. The anatomy of the fistula, the same as ultrasound, is identified considering the primary tract, whether it's a fluid field or fibrotic, location of the fistula in relation to the sphincter, clock position of the internal opening, secondary extension, any complication like abscesses or collection. Endoanal ultrasound versus MRI fistulography and the points of comparison. Endoanal ultrasound was found to be superior. Localization of the internal opening allows better delineation of the anal sphincter complex anatomy, while MRI was found superior regarding detection of the supra and the extrasphincteric fistula tract, in differentiation between active and fibrotic tract, and better detection of the side branches. Both are equally effective regarding detection of complication. Examples for cases presenting with perianal fistula diagnosed by endoanal and MRI. First case, a 47-year-old male patient presenting with left perianal discharge. MRI finding A and B axial T2 and stair-weighted images showing two fluid-filled intersphincteric fistula tract eliciting high signal abutting the internal anal sphincter at 1 o'clock in yellow arrows and 6 to 7 o'clock in red arrows. Image C, coronal T2 weighted images showing left intersphincteric fluid-filled fistula tract breaching the internal anal sphincter opposite the superficial portion of the external anal sphincter in blue arrow. Corresponding ultrasound images, image A revealed a hypoechoic fistula tract seen within a left anterior intersphincteric space abutting the internal anal sphincter opposite 1 o'clock in yellow arrow. Image B, another hypoechoic tract seen within a right posterior intersphincteric space abutting the internal anal sphincter between 6 and 7 o'clock in red arrow. Image C, example of the coronal reconstruction. Ultrasound images showing left intersphincteric hypoechoic fistula tract in blue arrow breaching the internal anal sphincter opposite the superficial portion of the external anal sphincter. Second case, a 55-year-old male patient presenting with left perianal discharge and pain. Image A, axial T2 weighted images showing left transsphincteric fistula tract breaching the superficial portion of the external anal sphincter opposite 12 to 1 o'clock in yellow arrow. Image B, coronal stair weighted images showing high signal transsphincteric fistula tract ending just below the inferior margin of the left sling of the puborectalis muscle in blue arrow. Corresponding ultrasound images, image A and E and B, axial ultrasound images showing left hypoechoic transsphincteric fistula tract breaching the subcutaneous and superficial portion of the left external anal sphincter at 12 and 1 o'clock in yellow arrows. Image C, the example of post-reconstruction ultrasound coronal images showing left transsphincteric fistula tract in blue arrow breaching the deep and superficial portion of the external anal sphincter. Third and last case, a 34-year-old male patient presenting with left perianal discharge. MRI finding A, B, and C, axial and coronal T2 weighted images showing left anterior intersphincteric fistula tract with fibrotic wall in yellow arrows, ending cranially with a small intersphincteric collection abutting the internal anal sphincter between 12 and 2 o'clock in blue arrow. Image D, axial stair weighted images showing a side branch of high stair signal arising from the collection and running posteriorly, abutting the left aspect of the rectum in red arrow. Corresponding ultrasound images, image A and B and C, axial and coronal ultrasound images showing left anterior intersphincteric hypoechoic fistula tract, ending with left intersphincteric collections with internal echogenic foci breaching the internal anal sphincter between 12 and 2 o'clock in blue arrow. Image D, the ultrasound axial images show a hypoechoic side branch arriving from the collection and running posteriorly in red arrow. In conclusion, endoanal ultrasound was preferable to MRI in the localization of the internal opening, while MRI was preferable to endoanal ultrasound regarding the detection of the extra and suprasphincteric fistula tract and the fibrotic tract characterization. Both MRI and endoanal ultrasound are considered to be complementary to each other for optimal diagnosis of perianal fistula and reducing the rate of the post-operative recurrence. Thank you.
Thanks, Dr. Ala, for his excellent talk.